Good evening, everyone. I am Chokila Ladingpa, Joint Secretary, Panpharmacon Student Club, Department of Pharmacology, MSRUS. I'd like to welcome you all to this webinar on a clinical pharmacist's role in managing sodium level of patient in hospital setting by Dr. Mohammed Salim, Assistant Professor, Department of Pharmacy Practice, Mahe Manipal. Before starting, I'd like to inform the participants that the microphones have been disabled for the smooth conduct of the webinar. However, the chat box option will be open for you to post any queries. Now, I'd like to invite Ms. Tanuja, Assistant Professor, Department of Pharmacology, FPH MSRUS, to introduce Dr. Mohammed Salim.
Good evening to one and all. On behalf of Department of Pharmacology, Faculty of Pharmacy, Ramaiah University of Applied Sciences, I, Tanuja, Assistant Professor, Department of Pharmacology, extend a warm welcome to all for the webinar on clinical pharmacist role in managing sodium level of patients in a hospital by Dr. Mohammed Salim. It's my privilege to introduce to you our eminent speaker, Dr. Salim completed his PharmD in 2016 from Kerala University of Health Sciences, Kerala. He obtained his PhD from Annamalai University in the year 2021 for his research work, drug utilization evaluation of ACE inhibitors and angiotensin receptor blockers in hypertensive patients with chronic kidney disease. He is a qualified clinical pharmacy mentor and researcher, currently working as assistant professor in Department of Pharmacy Practice, Manipal College of Pharmaceutical Sciences, Mahe, Manipal. Before he joined Manipal College, he served as assistant professor and clinical preceptor, Department of Pharmacy Practice at KIMS, Al Shifa Hospital, Al Shifa College of Pharmacy, Kerala University of Health Sciences between 2016 and 2021. He is also a member in Federation for Clinical Pharmacists of India. He is the director and editor of two YouTube channels, Medicine Assistant and Pharmoria, and also a founder of Drug Information and Drug Patient Counseling mobile application, Dr. Med. His other research areas are education and skill improvement programs, quality improvement programs, and novel concept to evaluate the standards of pharmacy education, chronic kidney disease, COVID-19 treatment and vaccines, and also health IT. Dr. Salim published more than 15 research articles in various reviewed journals and serving as a reviewer in many journals. He has attended many conferences and workshops, also contributed as a resource person in several scientific meetings and workshops. With this brief introduction, I welcome Dr. Mohammed Salim to take over this session.
Yeah, thank you for the sweet introduction. Thank you so much, madam. Uh, can I share my slide? So good afternoon, ladies and gentlemen. I'm here to give a brief introduction about clinical pharmacist role in managing sodium level of patients in a hospital settings. We pharmacy practitioners usually go to clinics to review a patient. We find so many patients with comorbidities. We find patients with multi comorbid conditions. We review their prescriptions. We find the appropriateness of each medicines. We check the drug-drug interaction, drug-herb interaction. We find the adverse drug reactions. We initially we look into the medication, like we do the medication reconciliation, and so many activities we do in the clinics, and they are all confined to drugs. However, we are less focusing on the electrolyte part. You know that how much electrolyte are vital for our normal physiology. There are like sodium, potassium, chlorine, magnesium, phosphorus. So many electrolytes are there which are very much vital and have a major role in our in our body function. So this is just a stepping stone for you, or rather, I would like to promote you to look into the sodium aspect of each patient and give an insight on how your sodium or the patient's sodium level can be monitored and managed. So, so this is my disclaimer. So what am I going to discuss? Like what we are going to have in detail or briefly in this session. So I'll be going to give you a brief description about aspects related to sodium homeostasis, and then I'll be looking into the hypertonic saline or hypotonic saline, the particulars regarding the hypertonic and hypotonic saline, and how we can manage a patient with hyponatremia and hypernatremia. So these are the main portions that we'll be covering in today's session. So today's my goal is to make you understand the importance of sodium homeostasis in a healthy individual as well as a patient, and then make you aware of the essentiality of proper management of serum sodium abnormalities, mainly hypernatremia and hyponatremia. Then you need to look into the adverse event associated with improper treatment. So these are the main three goals that I would like to attain after completing this session. So as an introductory portion, you should know about what is the total body fluid and its composition, what is crystalloid and what is colloid, and how we can do fluid resuscitation, and what is maintenance intravenous fluid. So we'll be discussing about each of these components. First, we'll be going into the total body fluid. The total body fluid is about estimated to be 60 percentage of the lean body weight in a male person, and 50 percentage of lean body weight in a female person. So if you look consider a 70 kg adult, there'll be about 42 liter of total body fluid. So here you can see the water comprise of 60 percentage in within the cell, and outside the cell there'll be 40 percentage of body fluid. So you know that cell can transport easily water into it, and in the extracellular space we have the electrolytes. They have various electrolytes are present in the extracellular space, and within the extracellular space we have the intravascular space as well as the interstitial space. So here you can see among the 40 percentage we have 75 percentage intracellular space comprising of the fluid, body fluid, and the remaining 25 percentage is present within the intravascular space. So this is the composition. This is how the total body fluid are present in the body. So now we'll be going into the intravenous fluids. You know that these either we look into there are mainly two types of plasma expanders. One is the crystalloid and second is the colloids. Crystalloids, you have so many examples that are widely used in a hospital or a clinical setting. You know that there are normal saline, there are lactated ringer, you have normosol R, you have plasma-lit, we have 5% dextrose. These are some of the crystalloids that are widely used in a clinical settings. You know that they can normal saline. You already know it contain sodium and chlorine. When you look into lactated ring, it contains sodium and chlorine as well as lactate, then potassium and calcium. Whereas normosol R and plasma lit contain sodium chlorine, acetate, and it also contain magnesium, and potassium. And dextrose, you already know it contains dextrose. So this is how the composition of a crystalloid, composition of different crystalloids that are widely available in market. So here you can see, if you are giving 1000 ml of these three components, the normal saline, lactated ringer, normosol R, and plasma lit, the plasma expansion or the volume of plasma that will expand is about 250 ml. Why this happens? Have you wondered? This is mainly because sodium and chlorine that are mainly present in the extracellular space. It is not freely permeable to the cell. So they remain in the extracellular space. And here you can see only 25% of the volume of the liquid that is infused will get into the intravascular space. So if you calculate, if you multiply 1000 into 25%, you will get to 50 ml. So that's how there is a change in that's how it happens. So 1000 ml of these three solutions will give 250 ml of plasma expansion. Whereas here you can see 5% dextrose. If you're administering 1000 ml, you'll get only 100 ml. Why this happens? This is because dextrose is rapidly metabolized and it is converted into water and carbon dioxide. So you know that water can get into the cell. So 60% get into the cell and only 40% is available in the extracellular space. So if you multiply 1000 into 40%, you will get 400 ml. Among that, 25%, if you calculate, you will get 100 ml. So that is how the dextrose is 1000 ml. If you infuse, you'll get only 100 ml. So this is how this works. And the main issue behind giving 5% dextrose is like when you have some brain injury, if you give dextrose, it can hydrate the brain cells and thereby increase the intracranial pressure, thereby causing fatal impact. So you should not give 5% dextrose to a patient who is having brain injury. Moreover, they can also lead to hyperglycemia. It's like 5 gram in 100 ml. It can produce about 17 kilocalories per 100 ml. So in hyperglycemia or in a brain injury, it is not that much recommended. However, it is according to the patient condition, it might have a use. And further, we have the colloids. So colloids are comparatively having more or larger molecular weight. It consists of like packed RBC. Then we have the albumin, which are available in different concentration, 5% and 25%. And then we have the semi-synthetic formulations like dextran. Then we have hydroxyethyl star 6%. Because it's it's having high molecular weight, they are mainly confined or they settle within the intravascular space. They can't get into the cellular space. So that's why if you administer 500 ml, it give a 500 ml expansion in both these cases. And have you wondered why 25% albumin produce a much greater expansion with a small volume of liquid? It's because the 25% albumin is having an effect called oncotic effect. Oncotic effect means it pulls the water from the cell into the intravascular space. It is having five-fold action than that of a plasma. So that's why 100 ml, if you infuse, it will give 5 times more action so that 500 ml of plasma expansion happens. So this is a description about the crystalloid and colloids. So these are widely used in hospital settings, so you should know the differences. So now we'll go to the fluid resuscitation and how this fluid resuscitation happens. So fluid resuscitation is demanded or required when the intravenous fluid depletion happens. This usually happens in a patient with shock, either hypovolemic or septic shock, where there is a decreased cardiac function and oral hypoperfusion. So the symptoms usually happens when there is a 15% blood volume loss or about 750 ml of blood is being lost, or sometimes the the blood volume or the blood components will move into the intracellular space, or the sodium will move into the intracellular space. So that's why in that condition, either of these conditions, the signs and symptoms of IV fluid depletion is seen. So what are the signs and symptoms? So first is tachycardia. That is if the heart rate is above 100 beats per minute, we call it as tachycardia. Then we have hypotension, where the systolic BP is greater than less than 80 millimeter mercury. Then there'll be orthostatic changes associated with heart rate and blood pressure. Then the blood urea nitrogen and serum creatinine ratio will be elevated. That is, it will be 20:1, and there'll be dry mucosal membrane. There'll be decreased skin turgor. Then the urine output will be low. The patient may encounter dizziness. And once the treatment has been initiated, heart rate and blood pressure will be normalized. So these are the main signs and symptoms associated with intravenous fluid depletion. So what are the goals? As a pharmacist, as a clinical pharmacist, as a healthcare provider, what are our goals in terms of fluid resuscitation? The first thing is restore IV volume. So we need to restore the volume that has been depleted. And then that's how once the volume is regained, then it can prevent organ hypoperfusion. So how can this happen? It can happen by administering a suitable IV fluid. It should be rapidly infused, and preferably it is given by large bore catheter. So administer 500 to 1000 ml of a suitable IV fluid can be done. Once it's done, then we need to re-evaluate. If the signs and symptoms are not going, then we should continue with adequate uh, fluid. Uh, so we can use either 0.9 percentage NaCl. We can use the ringer lactate solution. Some studies like ringer lactate solutions are mainly typically used in practice, mainly in surgeries and traumas. However, the evidence of or superiority of this ringer lactate over 0.9 percentage NaCl has not been established. However, the ringer lactate, as I mentioned in the previous slide, ringer lactate contain lactate, which get metabolized into bicarbonate. You know that bicarbonate is an effective treatment option for metabolic acidosis. So if a patient is having metabolic acidosis and lactated ringer is being administered, this bicarbonate produced as a result will help to produce a better impact on the patient. However, but the shock patients will have an impaired lactate metabolism. So shock patients, the patients who are having shock, will not get benefit out of ringer lactate solution. So that is something different. This is how you give the this is how you do the fluid resuscitation program. So here we have the what are the main difference between, you might be wondering why crystalloids and colloids are different. As I mentioned in the previous slide, there are many differences, but in terms of clinical outcome, patient outcome, and time to achieve fluid resuscitation, both are having no differences. So there are no differences in the time to achieve fluid resuscitation or patient outcome between the two agents. And the colloids are having high cost, and some adverse drug reaction has been reported with colloids. So if you look into dextran or hydroxyethyl starch, that can lead to some coagulopathy, or they can also cause acute renal injury. And if the 5%, 6% hydroxyethyl starch is being administered to a kidney impaired patient in a critical ill condition, they can even die. So adverse drug reactions are much confined to colloids. So when can we shift to a colloid? So if once you start an electrolyte, and you have administered 4 to 6 liter of a crystalloid, then it's not functional. The hemodynamic goal has not been attained. Then you can shift to an colloid. Or if there is hypoalbuminemia, there is a low albumin in the blood, and the patient require large volume resuscitation, then in that case, you can give 5% albumin. So that's a colloid. And if there is edema, a patient is having edema and albuminemia is there, you can give 25% albumin supplement. Along with that, diuretic should be given. So these are some of the options that uh, that can be given, like the colloids can be given in these kind of situations. So next we are going to maintenance IV fluid. So when we are going to give maintenance IV fluid, once the patient is not able to tolerate oral fluids, the main goal of giving maintenance fluid is to prevent dehydration, and the foremost second point is to normalize the fluid and electrolyte. So how can we administer maintenance fluid? That is through continuous infusion, either through peripheral or central IV catheter. So these are the options how we provide or administer maintenance fluid. So in order to administer a maintenance fluid, we need to calculate the daily volume of fluid in a patient or an individual. For an infant, for a pediatric patient, the calculation is like 100 ml per kg for 10 kg of the patient's weight, and then followed by 50 ml per kg for 10 to 20 kg. And for each 1 kg rise in weight, we should give an additional of 20 ml per kg. So this is how we administer for a pediatric patient. In adult case, we have 20 to 40 ml per kg per day. That is the daily volume of fluid required for an adult. And that should be adjusted according to the each individual patient based upon their input, output, and estimated other loss. So according to this, the requirement of daily volume may change. So if I give an example, like what is the requirement of daily volume of fluid in a 20 kg child? So it is like 1,500 ml of fluid. How we get this? We need to split 20 kg into 10 plus 10. So 10 kg from this calculation, from this equation, we can multiply 100 ml into 10, that will give 1000 ml. For next 10 kg, we can multiply with 50 ml. So we get 50 into 10, we get 500. So combining these two, we get 1500 ml per day. So if we have a further increase if you have a patient with 21 kg, we need to add 20 ml. So then it will become 1520 ml per day. So that's how the calculation of daily volume of fluid for each patient. So typically for a maintenance fluid requirement, usually physicians or clinicians or healthcare providers provide these three components together. That is 0.45% NaCl, 5% dextrose. Along with that, they give 20 to 40 milliequivalents per liter potassium chloride. This depends upon the patient. Potassium chloride should be administered based upon the patient's potassium requirement. So this is how typically a maintenance fluid is being administered to a patient. So I'll give a case for you. If we have a metabolic patient with metabolic acidosis, sodium bicarbonate should be given. And the physician has ordered for giving sodium bicarbonate, and the nurse mixed the sodium carbonate 150 milliequivalents with 850 ml of 0.9% NaCl. So do you think it will retain its normal saline property? Actually, it will not retain its normal saline property. So that it will lead into a different concentration, that is NaCl will be changed into 1.6 percentage. So that will produce an undesirable impact on the patient. So in that case, how can you give sodium bicarbonate? So if the patient requires 150 milliequivalents per liter of sodium bicarbonate, we need to mix with dextrose 5% or sterile water for injection instead of administering with 0.9% NaCl. So each drug, each component has a specific diluent in which they should mix, so that you should have an idea. Otherwise, it can produce a fatal impact. So next important part is the plasma osmolality. So the normal plasma osmolality is 275 to 290 milliosmoles per kg. And in the plasma, the osmolality and osmolarity are almost equal. Less than 1% difference is there. So how do you calculate the osmolality? Osmolality is calculated by 2 into serum sodium in milliequivalents per liter uh, plus glucose in mg per deciliter, sum plus blood urine nitrogen in mg per deciliter divided by 2.8. So this will give us the plasma osmolality. So why it is relevant? If you have a plasma osmolality increase, it can lead to cellular shrinkage. If you have a plasma osmolality decrease, then the cellular overhydration happens and swelling happens. So that's why calculating the osmolality is important. So now we have different concept, different type of solution, salt solution. There's isotonic solution, hypertonic solution, and then hypertonic solution. So in isotonic solution, the osmolality between the intracellular compartment and extracellular compartment are same. In that case, there will not be a shift of water between the two compartments. And in hypertonic solution, there will be shift of water from intracellular compartment to the extracellular compartment. That's why the cellular shrinkage and dehydration happens. In hypotonic solution, the water shift from extracellular compartment to the intracellular compartment. That's leading to overhydration and swelling. So this is how each solution uh, processes. So coming into each different solutions, if you look into hypertonic solution, we have 3%, 7.5%, 23.4% of hypertonic solution. So you can see the corresponding osmolarity of each salt solutions. So these hypertonic solutions are mainly indicated for two different conditions. One is the traumatic brain injury. When this happens, the intracranial pressure will be greater than 20 millimeter per mercury, millimeter mercury. So if it is high, greater than 20 millimeter mercury, this hypertonic solution can be given. And the second indication is symptomatic hyponatremia. So symptomatic, there should be some symptom of hyponatremia, and the sodium level should be less than the normal range. So in that case, you can say it is less than the normal range. It should be less than 120 milliequivalents per liter. If it goes beyond below 120 milliequivalents per liter, and there's a symptom, usually if it goes beyond, I'll be showing those kind of symptom differences in the future slide. So if it is going below 120 milliequivalents per liter and the patient is showing symptoms, then we should give hypertonic solution. So there are some situations in which we should not give hypertonic solution. The first condition is chronic asymptomatic hyponatremia, where instead of giving sodium, we should have a fluid restriction. The second condition is hyponatremia associated with severe hyperglycemia. So this usually happens if the sugar level is high or the patient's having some diabetes mellitus. So each increase in 100 mg per deciliter of sugar will decrease the sodium level by 1.6 milliequivalents per liter. So in order to understand what is the actual sodium present in the body, we need to have the corrected sodium calculation. That is serum sodium uh, plus 1.6 into glucose in mg per deciliter minus 100 divided by 100. This will give you the corrected sodium, and if the patient's glucose level is measured in millimoles, then the equation is becomes serum sodium plus 1.6 into glucose in millimoles minus 5.6 divided by 5.6. So this will give us the actual sodium present in the body. And the last condition where we shouldn't give hypertonic solution is hyponatremia associated with hypervolemia. So when there is an excess volume in the body and sodium level is low in that particular scenario, we should not give hypertonic solution. So here is another case. We should prepare a 1000 ml solution with sterile water for injection, and that should have 7.5% hypertonic solution. So the hypertonic solution what we have is 23.4% NaCl. So how can you make the calculation? So here we have this hypertonic solution that is 23.4%, and then we have the water for injection, which the percentage is 0. And we require to create 7.5 percentage of 23 percentage normal saline. So the remaining part will be a subtraction or difference between 7.5 to 23.4. So there'll be 15.9 parts of sterile water. So here we do the calculation, the math in which the 7.5 parts divided by 23.4 part will give the 23 percentage sodium chloride required in 1000 ml. And then similarly, we do the math for the sterile water. Ultimately, we'll get a volume of 23.4 percentage NaCl. It's simple mathematics where you get the 23.4 percentage NaCl and about 679.5 ml sterile water. So this is how the calculation is being done. So what is the dose required when a hypertonic saline is being administered to a patient? So I mentioned there are two main indications in which you should give hypertonic saline solution. One is the traumatic brain condition, and second is the symptomatic hyponatremia. So in traumatic brain or other neurological injuries, a 3% hypertonic solution should be given. That is 250 ml. Either you can go with measure with the weight of the patient, 2 to 4 ml per kg, infused over 1 to 15 minutes. So this is how you administer 3% hypertonic solution. Or we can go with other dosing, that is 23.4% hypertonic solution. 30 ml can be infused over 20 to 30 minutes. So if the intracranial pressure is not lowering, then you can give 4 to 6 hourly. This 20 to 30, instead of this, we can give 4 to 6 hourly. Or still, if it is not reducing, then we can give 3% hypertonic solution as a continuous infusion. So these are the some of the options you have if you have a hypertonic, if you have a traumatic brain injury or a neurological injury. And the second indication, as I mentioned, we have the symptomatic hypernatremia. So in this particular situation, hypertonic saline can be given to normalize the serum level to a specific extent. The rise should be small but quick. It should be quick enough so the actual rise per hour should not go beyond 0.7 to 1 milliequivalents per liter. This concentration should be checked until it reaches the serum sodium level reaches 120 milliequivalents per liter. So in a day, it should not go beyond, the serum sodium should not increase, or the increment should not go beyond 10 to 12 milliequivalents per liter per day. So once the patient have attained 120 milliequivalents per liter of serum sodium, then the increment criteria should be 0.5 milliequivalents per liter per hour. And this should be kept in mind. That is 10 to 12 milliequivalents per liter per day. So this is the checklist that is widely used and should be considered when you are administering any hypertonic solution to a patient. And it's if somehow it exceeds the maximum rate, you either should administer desmopressin, which is a vasopressin analog, or you should give dextrose 5% in water to prevent the overcorrection. So if overcorrection happens, then there'll be some symptoms, even it can lead to death. So this is a checklist for how you can decrease how you can improve the condition of a patient. So it is actually symptomatic hyponatremia. Sorry for the typographic error. So it is, I previously have mentioned, um, so it is given for hypertonic solution is given for two conditions: traumatic brain injury and symptomatic hyponatremia. So that's a typographical error. So don't get confused. So this is how you do the dose administration. So how you can, what is the infusion rate for a hypertonic solution? So it can be calculated by an ideal body weight. If the ideal body weight you are having for the particular patient, it should be multiplied by the desired rate of serum sodium increase in NR. So this we have already understood from the previous slide, where you can only increase the sodium level to maximum of 1 milliequivalents per liter per hour. So by if you have a patient with 70 kg, then you can multiply 70 kg with the maximum level of sodium increment per hour. That will give us the rate of infusion, and that is the infusion rate of hypertonic solution. So usually, typically, hypertonic 3% hypertonic solution, or hypertonic solution is infused at a rate of 1 to 2 ml per kg per hour. This is the usual practice. However, in is asymptomatic patient, usually it is not recommended. However, if some situation asymptomatic patients require any hypertonic solution, it should not go beyond the increase per hour should not go beyond 0.5 to 1 ml per kg per hour. So this is the requirement. So how we can administer hypertonic saline? So you should use a central IV line instead of peripheral IV line, because the osmolarity of the solution of hypertonic solution is more than 900 milliosmoles per liter. So that we have seen in the previous slide. I have shown you the osmolarity of each hypertonic solution. So if it is more than 900 millimoles per liter, then you should go with the central IV line. Otherwise, it can cause some damages or fatal responses. So if you do not have a central line, you can go with 2% hypertonic solution instead of the 3% hypertonic solution. However, certain studies have also shown, in contradictory to this, some recent studies have shown 3% hypertonic solution can be given safely through peripheral lining. So, however, you should measure the possibility of phlebitis or inflammation of the blood vessels. So, this usually happens when you are having an intravenous cannulation in the peripheral blood vessel. So, you should look for phlebitis in such cases. So, what are the clinical goals for a patient who is having a symptomatic hyponatremia being treated with a hypertonic solution? The first and foremost thing is to decrease the symptoms. And the second important thing, you don't need to make the serum sodium concentration to 135 to 145. Instead, you should make the sodium level to 120 to 125 milliequivalents per liter. And gradually you can increase further. So this is the first requirement in this kind of patients. So this will making into this value will prevent neurological adverse events. So I mentioned the per day increase of serum sodium should not be more than 10 to 12 milliequivalents per liter per day. So that's why they have given a goal of 120 to 125 milliequivalents per liter. That is the initial goal. And the serum sodium should be checked every 1 to 4 hours. So what are the complications associated with hypertonic saline? The first, if it is not administered properly, it can lead to osmotic demyelination syndrome. Sorry. So this is a condition in which the patients will have lethargy, and finally it may lead to persistent neurological damage, where initially there'll be weakness of one side and then lead to further full body paralysis, arthralgia, dysarthralgia will be there, and further the patient may die. So osmotic demyelination is widely seen if the sodium increment is beyond 10 to 12 milliequivalents per liter per day. If it goes above 10 to 12 milliequivalents per liter per day. And this can also lead to hypokalemia. Hyperchloremic acidosis can also happen. This is because you are administering chlorine along with like the sodium chloride, the hypertonic saline contain chloride also. So the chloride level also increases that can lead to hyperchloremic acidosis. So in order to prevent that, we can mix sodium chloride along with sodium acetate in 1:1 or 2:1 ratio. So that can prevent hyperchloremic acidosis. And then hypernatremia can happen if the dose is more or like the administration is not proper or exceed the limit. And phlebitis can happen. Hyponatremia can happen if the infusion is rapidly given. So these are some of the complications associated with hypertonic saline. So other consideration that should be kept in mind is the hypokalemia. So if there's hypokalemia along with hyponatremia, you should correct hypokalemia. So if you correct hypokalemia, then normally the sodium level will rise. That's the mechanism. Next, we have the hypotonic solution. That is, we have 0.45 percentage. Normal cell, we have 0.45 percentage sodium chloride. We have 0.225 percentage sodium chloride. So the thing is that you should look into the the osmolarity of the solution. So if the IV fluid osmolarity goes below 150 milliosmoles per liter, it can cause the cell to overhydrate and swell. And if the swelling happens in the RBC, it can lead to hemolysis. So that is dangerous. So that's why you should not administer sterile water alone for a patient. So that is it can lead to hemolysis or other fatal overhydration of cells. Some prescribers use hypotonic saline for hypernatremia, but for mild hypernatremia, water is more indicated than sodium. So you need to give water instead of giving sodium. Otherwise, you can give dextrose. So this is how you use hypotonic IV fluids. So the next important part or the main part is like if you have a reduced serum sodium that is less than 136 milliequivalents per liter, you say it as hyponatremia where you have the plasma osmolarity will be reduced. So this lead the water to shift from extracellular space to intracellular space that will lead to overhydration of the cell. So whenever we speak about hyponatremia, we need to classify them into different parts or different portions. First is hypovolemic hyponatremia. Second is hypovolemic hyponatremia. And last is hypervolemic, euvolemic hyponatremia, hypervolemic hyponatremia. So in case of hypovolemic hyponatremia, as the word suggests, the water and sodium will be low in the body. This is mainly because of fluid loss, maybe because of some drugs or some excessive diarrhea or something, any disease conditions that can promote sodium and water loss can lead to hypovolemic hyponatremia. In this case, you need to have a fluid, you need to opt for fluid resuscitation. Fluid resuscitation should be done. You know that previous slide I have mentioned about 0.9 percentage NaCl or lactate ringer can be given. The second case, if you have a euvolemic hyponatremia, the sodium will be normal, but water will be high. So it happens in certain conditions like syndrome of inappropriate antidiuretic hormone where water content will be more. So in this case, water restriction should be done and some drugs like vasopressin receptor antagonists can be promoted. So that's why this is how you treat the euvolemic hyponatremia. So in the last case, hypervolemic hyponatremia, sodium and water will be high. So this usually happens in heart failure and cirrhosis. So in this case, you need to restrict sodium and water, and then you can also give vasopressin receptor antagonist, and then it should be also facilitated by diuretics. So this is how you have a different types of hyponatremia and how they are being treated. So there is a special condition called hyponatremia. This usually happens. The serum sodium level will be low, with normal or elevated plasma osmolarity. This we have previously discussed in our slide. This usually happens in case of severe hyperlipidemia and severe hyperglycemia. So once this is corrected, you can have a normal sodium level in the blood. So the main thing is that we need to know what is the factor that led to hyponatremia. So that's why the pseudo hyponatremia is also important. So if you have these kind of patients, you need to treat the patient with the uh, uh, and hypoglycemic agent or hypolipidemic agents. So, and then once that is done, when the blood levels are normal, the sodium level will also come to a normal. So, what are the symptoms that can happen with hyponatremia? So, the symptoms will vary upon the serum sodium concentration. So, if it is 120 to 125 milliequivalents per liter, then the patient will have nausea and malaise. If the serum sodium is between 120 to 115, the patient will have headache, lethargy, unsteadiness, and confusion. And if it goes below 115, the patient will have severe symptoms like delirium, seizure, coma, respiratory arrest, and further patient may die. So these are how. So usually, if it goes beyond 120 milliequivalents per liter, we should give hypertonic solution, hypertonic saline solution. So, how the symptoms happen? So, as I mentioned, in case of hyponatremia, the osmolality will be less. Plasma osmolality will be less. This lead to uh, overhydration of the cell. So, the brain takes up water. It lead to cerebral edema. So that's why the symptom happens. And there's a condition like called chronic hyponatremia, where the patient does not show any symptoms. This is because the brain or our body has a mechanism called osmotic adaptation, where once the cerebral cells or the brain cells is hydrated or hydrated, it have a tendency to send out solutes out of the cell, thereby pushing water out of the brain cells. And this lead to regaining of the water content or the regaining the property of the cell. So this happens in a chronic condition. This lead to normalizing of the homeostasis of sodium between the extracellular space and the intracellular space. And these patients, because of chronic hyponatremia, there will be no symptoms, or at least there will be less symptoms. So that's why in this case, probably the patient won't require any treatment because there will be no signs and symptoms. And acute hyponatremia usually occurs in 1 to 3 days. That should be kept in mind. So how do you treat hyponatremia? So first thing is to treat the underlying cause. So if you have a hyperlipidemic patient, you should treat the hyperlipidemia. If you have a hyperglycemic patient, you need to treat the hypoglycemia and then go with the sodium correction. So, and the key point that should be kept in mind is that the serum sodium rise should not go beyond more than 10 to 12 milliequivalents per liter per day. And the treatment all depends upon the volume status, the presence and severity of symptoms, onset of hyponatremia. So if the patient is euvolemic, that I have previously mentioned, the sodium level is normal and water content is high. Or edematous condition, we have sodium and water that is high. Sodium and water is high. In those cases, if the patient is asymptomatic, then we should have a fluid restriction case of euvolemic patient. In case of edematous patient, we need to have a sodium and water restriction. And why the vasopressin antagonist can be given, like tolvaptan, cornivaptan can be given. So once they are administered, it lead to accuracies, that water is eliminated. Sodium natriuresis or sodium elimination will be reduced. That lead to increased sodium level in the blood, reduced symptoms, and weight will be reduced. However, the clinical outcomes are not that much significant, or the quality of life of the patient is not that much improved, or hospital stay won't improve. That is the drawback of giving vasopressin antagonist. And the cost is also high. And further, if you do a fluid restriction and give vasopressin antagonist, it lead to overcorrection. What is overcorrection? We have already discussed is more than 10 to 12 milliequivalents per liter per day. It will go beyond above that range, and this lead to it can lead to osmotic demyelination syndrome, hypokalemia, all those issues will be there. So, and one more thing is that tolvaptan should not be given for more than 30 days. So if it is given more than 30 days, can lead to liver damage. So if along with this, for the patient with edematous condition of hypervolemic hyponatremia, we should give diuretics to remove the water from the body. So in this patient, if you have an IV volume depletion, the first and foremost thing is to give the patient IV crystalloid, preferably a 0.9% NaCl. So during the correction, during the IV NaCl administration, the ADH antidiuretic hormone will be secreted. Once that is secreted, you know that it leads to water retention and thereby can lead to hyponatremia. And once the restoration is done, this ADH secretion will be reduced, whereby it can lead to overcorrection, and that can lead to some problems. So what I meant to say that you need to have a checks on the sodium level. That's why every 1 to 4 hours, the patient's sodium level should be checked, even if you are giving an adequate treatment option. So you have an the IV volume, intravenous volume is restored. Then we should check for the sodium deficit. So sodium deficit should be calculated. So this is the equation for calculating sodium deficit. So 0.5 into lean body weight of the patient into 140 minus serum sodium in milliequivalents per liter will give the sodium deficit for a women patient. So if it is a male patient, you need to multiply with 0.6 to this equation. And then you can have that about 25 to 50% of the above sodium deficit can be given, can be corrected within 24 hours. So make sure that it doesn't go beyond 10 to 12 milliequivalents per liter per day. So one more thing that I previously mentioned is that if you have a patient with hypokalemia and hyponatremia, if you correct hypokalemia, it may also increase the sodium level in the patient. So if you have a scenario in which a patient is having hypokalemia and hyponatremia, and the physician asks you, what should I give? You should say that I should give potassium supplement. Preferably, it's that like if there is a 1 milliequivalents per liter you want to increase 1 milliequivalents per liter of potassium, you need to give about 200 to 400 milliequivalents of potassium chloride per day. So that if you give a potassium, then the hyponatremia can be corrected somewhat. The first treatment is to correct hypokalemia. So coming to hypernatremia, you know that the serum sodium level greater than 145 milliequivalents per liter will increase the plasma osmolarity, and this lead to shrinkage of the cells. So that is what we call hypernatremia. It usually happens if the water is being lost from the body, either because of fever, burn, renal loss, GI loss, and either it can be retained the body because of some of the drugs. So how can you prevent hypernatremia? So we need to maintain the plasma osmolality between the normal range, that is 275 to 290 milliosmol per kg. And there are some physiological functions that are happening in our body that you know that there's antidiuretic hormone and the thirst mechanism. So why I mentioned is that usually hypernatremia happens in altered mental status condition, like the patients who are having mental status issues, who are having psychiatric problems, who are not able to process the thirst, or who is not able to ask water, they'll have hypernatremia. And infants also will have a hypernatremia because they are not have a tendency to ask for water. So the usual symptoms, early symptoms are lethargy, weakness, irritability, and if it goes above 158 milliequivalents per liter, it can progress to muscle twitching, seizure, coma, and further into death. And then the cerebral dehydration, as I mentioned, cerebral dehydration can happen because the cerebral cells will shrink or the brain cells will shrink because of hyperplasma, increased plasma osmolality. So the vein rupture happens. So these are the symptoms that happen because of hypernatremia. So how to treat hypernatremia? That the thing that is that I mentioned regarding hyponatremia also applies to this condition also. Rapid correction should be prevented. If it is rapidly corrected, cerebral edema, seizure, permanent neurological damage, and death can happen. So how can you correct? Or what is the checklist for correcting hypernatremia? So it should not go beyond the increase in sodium level should not go, the decrease in sodium level should not go above 0.5 milliequivalents per liter per hour, or should not increase 12 milliequivalents per liter per day. So in the previous case, hyponatremia, we gave sodium. And here in the previous case, we discussed about sodium deficit. Here, water is being lost. So we need to calculate the water deficit. And the water deficit should be corrected over several days, not in a single day. So how can we calculate the water deficit? It is calculated by 0.5 into lean body weight into serum sodium in milliequivalents per liter divided by 140 minus 1. So if you this is the value for the female, and then if you multiply by 0.6, you'll get the value for the water deficit for male. So I mentioned that you should give oral or enteral or just this oral water should be given. If water the patient can't take water, you can give IV dextrose 5% can be given. So in this patient, if further this patient got concurrent sodium and water depletion, then in that case dextrose 5% combined with 0.2 to 5% normal saline can be given. It is a hypotonic solution. In order to rectify the patient's condition, you can give um, dextrose 5% and hypotonic sodium chloride so that the tissue gets enough water. And suddenly, if the patient got hypotension because of IV volume depletion, you need to restore. If there is intravenous volume depletion, you need to go for 0.9% sodium chloride. If the patient is having diabetes insipidus, you need to give desmopressin, which is a vasopressin analog. So that is the treatment options for different types of hyponatremia. So in conclusion, if you have a patient with hypo or hypernatremia, we need to review the patient properly, should correct the sodium without exceeding the limit. If it is overcorrected, then it can lead to fatal responses, so it is not recommended. So this is a brief description about hyponatremia and hypernatremia. So thank you so much for patiently listening to this session. It's just a brief description of hyponatremia and hypernatremia, and then you need to learn about potassium supplementation, then calcium supplementation, and their homeostasis. So many electrolytes are important, and then you should have a good, you should give good suggestions to get the patient with a normal electrolyte. So that's all. If you have any questions, if I know, I will try to answer them. Thank you.
Thank you so much, sir. That was indeed a very informative talk. We shall start the Q&A round now. Dear participants, your microphone have been enabled. You can unmute and ask questions directly to the speaker or post your queries in the chat box. So there's a question posted in the chat box.
Yeah, can you explain the case once the calculation, how it is 1.6 percentage NaCl? So it's like you're giving 0.9 percentage NaCl, and then you have sodium bicarbonate, which also contains sodium. So it will add up sodium. So that's how it increases the sodium concentration. This is also happens if some drugs are having sodium salts. So like so diclofenac sodium is there. So once you give sodium diclofenac sodium along with some uh, sodium supplement, it can add all those sodium and further lead to increased concentration of sodium.
Thank you, sir. So even I have one question. Why are complications of hypotonic saline mostly related to neurological impairment?
Because it's mainly related to water, you know that water can get transported anywhere, can go to any cells. So it gets into the brain. Mainly, if you have usually, if you have any issue with sodium, you usually show these. I have shown the symptom, and the range of symptoms that happen that is related to like depending upon the serum concentration of sodium, they show different symptoms. They are all related to brain. So as you know that water can transport easily across different cells, it goes into the brain. That it causes edema. Once edema happens, you know that all the neurological symptoms happen. So that's related to sodium transportation across the cell. Probably that might have answered your question.
Yes, sir. Thank you, sir.
Thank you.
Good evening, sir.
Yeah, good evening.
Myself, Purna from first year info. Actually,
Hello. Yeah.
how can we identify the hypertensive patients who has high sodium?
Your question was, how can you identify hypertensive patient with uh, high sodium?
Yes, sir.
Yeah, you can just measure the blood pressure. No, blood pressure will be high, and you can have measure the serum sodium level. So that will be high. Then it means that BP will be like two common. The subjective and objective evidence can be taken. You know that you do the SOAP analysis. Subject will show symptoms of hypertension, and the objective evidence you take the blood pressure, and then you take the serum sodium level, it will be high. Then you can easily understand uh, it is hypertension because of hypernatremia.
Okay, sir. Thank you.
Hello, Mr. Salim. Good evening.
Hello, good evening, sir.
So I'm Dr. Shabi from Icon Pharmacology, head of the Department of Pharmacology.
Oh, hello, sir.
It was a good session.
Oh,
I
thank you,
just
sir.
went through. This is a hyper. I mean, hypertension related. Maybe hyperkalemia or the hypernatremia related question. So, what are the current research related to this topic? Is there any current research which would be, which could be like, useful for the PG students or those who are going for, register their PhD related things? Is there any current research related to the clinical pharmacy?
Yeah, maybe like there are so many case reports have been identified because of sodium overcorrection. So I have mentioned like if sodium is overcorrected, like 10 to 12 milliequivalents per liter per day, if it goes beyond that or above that, it can cause osmotic demyelination. So that is a severe condition. We usually neglect them, or patient don't know how this sodium can cause this much wide range of disease condition. And I personally have encountered a patient who was a pregnant lady who was overcorrected with sodium. Further, she experienced osmotic demyelination. Her baby was terminated, and then she eventually died. She was about 21 or 22 years of age. So this part is usually neglected in a hospital. This is where a pharmacy practitioner or a pharmacy professional should look into, like how much sodium increment is happening in an hour or in a day. So that should not go above that limit. So calculating the sodium deficit and accordingly administering the sodium solution is very much important. So there are so many case reports. I have also published this patient's case in a journal. So I think looking into this aspect is something good as a pharmacy professional. So they can, or potassium also similar way. If there is an increase in potassium level or decrease in potassium level, ECG changes can happen, and how you need to what is the amount of potassium that you need to give to the patient who is having a low potassium level, and how much amount of magnesium you should give for a patient with a low magnesium level, and those phosphorus, all those components. So we like it's a good area. I think I have not gone through researches because I have not published any paper. I have not went through these kind of electrolyte portion, but I personally have a case report which is very like the incidence, like the event is very fatal. Like a pregnant lady who is young who died because of sodium overcorrection is very bad. So that's an area where a pharmacist can, professional can do something good.
Okay, thank you, Mr. Salim. And this type of case study or the patient reports, case studies is going on in Manipal University, especially in the hospital sector.
Sorry, can you repeat the question, sir? I
So
didn't know.
this type of case study, research case study, or the clinical based education research study is going on in Manipal Hospital, which would
Yeah,
be helpful
yeah,
for the students, especially PharmD students or PG
yeah,
clinical or hospitals. So,
yeah,
yeah,
absolutely, sir. It will be useful. It should be there in a pharmacy professionals academical like academical time, so that they learn about how a drug should be diluted with the diluent, and what is the sort like this kind of electrolyte aspect should also be studied. So it is important. Like as we consider other drugs in practice, similarly we should also look into the electrolyte portion and the dilution of the drugs, intravenous drugs
mm,
is equally important.
okay. Thank you, Dr. Salim. Actually, this is my personal thing, a personal question. It's not question, just I want to know. Dr. Sonal Sekhar is along with you in Manipal.
Yeah, he's here. Yeah,
Is okay, okay.
yeah.
He was
Okay.
my colleague in
Oh,
the
great.
American Institute of Medical
Oh,
Science
great. Oh, great.
in
That's great.
2010 and 9.
Okay. Okay, that's great.
Thank you,
He's
Dr. Salim.
currently in vacation. He'll be coming maybe tomorrow.
Yeah.
Okay.
Convey my regards to Dr.
Oh, sure,
Salim.
sir. Nice meeting you, sir.
You too. Thank you. Thank
Yeah,
you so much.
thank you, sir.
Dear participants, we are open for the Q&A session. If any questions, you can ask the speaker. I'd like to invite Mr. Sashank, Treasurer, Panpharmacon Student Club, to deliver the vote of thanks.
It's my honor and privilege to conclude this session by extending word of thanks. First of all, I would like to thank Honorable Chancellor Sir and Vice Chancellor Sir for their continuous encouragement and support to conduct this webinar. On behalf of Panpharmacon Student Club, Department of Pharmacology, I would like to thank our Dean, Dr. Bharat, for his valuable guidance. On behalf of Panpharmacon Student Club, Department of Pharmacology, I would like to thank Dr. Salim for generously accepting our invitation and delivering this talk. Last but not the least, I would like to thank all the participants for their active participation, presence, and support in making this webinar a noteworthy success. Thank you, one and all. Thank you, sir.
Yeah, thank you so much for the convener, Dr. J. Anbu, my teacher, I can say that, faculty coordinator, Ms. Gauri Nair, media coordinator, Damodar Naik A, for inviting me for this session. Thank you so much. And thank you, participants, for patiently listening to my session, for making you sit quiet for about 1 hour. Thank you so much.
Thank you, Salim sir. Thank you.
Yeah,
Thank you, Salim.
thank you.